Hi, today I'd like to talk a little bit about some research here at the Center for Autoimmune Liver Disease, specifically using MRI-based biomarkers of fibrosis in autoimmune liver disease. I have no disclosures. So today we talked about the spectrum of autoimmune liver disease in children, including autoimmune hepatitis, primary sclerosing cholangitis, and autoimmune sclerosing cholangitis affecting the liver and bile ducts in kids and young adults. The focus of this research is on liver fibrosis and specifically as well as its complications. So liver fibrosis can progress to cirrhosis, and cirrhosis can cause what's called portal hypertension. And symptoms of that can be esophageal or gastric varices that may bleed, ascites or fluid collecting in the abdomen, hepatic encephalopathy, which can affect cognitive functioning, behavior, as well as alertness, and ultimately complications of cirrhosis requiring liver transplant. So we look at fibrosis and autoimmune liver disease with some special stains. So these are liver samples of tissue, one from primary sclerosing cholangitis, another from autoimmune hepatitis, and this is called a trichrome stain, where the collagen is stained blue, which shows kind of the fibrosis deposition, and the rest of the parenchyma parenchyma of the liver is red. You can see in primary sclerosing cholangitis this what we call pathognomonic, or we can very characteristic of PSC, with these kind of concentric circular collagen deposition surrounded around bile ducts. And here in autoimmune hepatitis, you have fibrosis around what we call the portal areas, with extension into the liver parenchyma as well. So the current status of fibrosis assessment in autoimmune liver disease, as likely many of you know and have experienced, is liver biopsy. It's required to help diagnose fibrosis. The hope would be that we can use imaging and circulating biomarkers to reduce the need for liver biopsy. And this might include magnetic resonance imaging or MRI sequences, circulating biomarkers of fibrosis coming from blood work. And this is a priority for research, both for the community as well as for us. There currently are new prospective studies looking at this in pediatric autoimmune liver disease, and we think that the fact that we don't have a way of looking at these biomarkers less invasively hampers clinical care, as well as the ability to design clinical trials for medication and therapy options for kids with autoimmune hepatitis and PSC. So the hypothesis of the study is that multimodal magnetic resonance imaging and circulating biomarkers can determine the severity of liver fibrosis and its progression over time in children and young adults with autoimmune liver disease. So the study methods for this project, it's a prospective study registered at clinicaltrials.nih.gov for children, adolescent, and young adults who are aged 6 to 25 years old who have a clinical diagnosis of autoimmune hepatitis, PSC, or autoimmune sclerosing cholangitis, and who have not undergone a liver transplant. Research MRIs occur yearly for 3 years, and clinical outcomes are compiled, including biochemistries, liver biopsies, and overall health status. So taking a look at the histopathologic assessment of the liver tissue, so for patients who've had a clinical liver biopsy within 6 months of a research MRI, the H&E, which is kind of the preliminary way of taking a look at liver biopsy, as well as the Massen's trichrome stain sections, which you've already seen examples of, are assessed for inflammation and fibrosis by pathologists who are blinded to the diagnosis that's associated with the liver tissue. Just a note about liver fibrosis staging, because we're going to be talking about two main fibrosis staging systems, and that's the ESHOC and the METAVIR. The ESHOC is from 0 to 6, and the METAVIR is from 0 to 4. And you can see representations kind of with pictures here about how we classify staining and kind of the relative relationship between the two. And so you can here at 0, you see no fibrosis, and going over, you see increasing fibrosis, including bridging fibrosis and cirrhosis. And these are the main ways that we'll look at fibrosis for these studies. Just to note that by convention, the literature and research talks about ESHOC of 4 or higher, or METAVIR of 3 or higher, being consistent with severe fibrosis. And so you can see that there's a variety of different levels of fibrosis within that. But by convention, we'll also use that as I go through the presentation. So patients underwent research MRI. This was using a 1.5 Tesla scanner with sequencing for MR elastography, which looks at the stiffness of the liver at 4 different areas, which is then averaged to take kind of an overall viewpoint. The advantage of MRI is that you can take actual individual digital slices of the liver. And so if you have areas of increased fibrosis, that can kind of average and get a better representation across the whole liver itself. There are some lab-based fibrosis assessments. One's called the OPRI score, and this uses liver enzyme elevation and platelet count, as well as the FIB4, which also looks at liver enzyme elevation, but also includes age. And so these are some non-invasive ways, mainly in the hepatitis, viral hepatitis literature, to look at fibrosis. So for this study, looking at kind of the results, these are the baseline characteristics of the study population. So 42 children and young adults with autoimmune liver disease, including 25 with autoimmune hepatitis, and the rest having either autoimmune sclerosing cholangitis or PSC. I'd like to highlight that the significant differences in this cohort are that there were far more kids who had autoimmune sclerosing cholangitis or PSC who also had concurrent inflammatory bowel disease. Interestingly, the platelet values were slightly lower for kids with autoimmune hepatitis. So this is a way that we take a look at having multiple pathologists reviewing tissue. Pathology is the gold standard for identification of fibrosis, but it's helpful to have an idea of how different observers and pathologists relate to one another. And for this study, you can see here that we had 3 different pathologists who took a look at the tissue, and I'd like to highlight that this ESHOC, which is just not the ESHOC fibrosis, but this is a way of assessing inflammation, seem to have some of the highest interrelated reliability when you look at individual reviewers compared with one another. And then you can see here that the ESHOC staging system and the Medivir classification, when you look at all the observers, had kind of had some interrelated reliability, but as you go to individual pairwise samples, that these were higher. And so for the purposes of this study, observer 3 had the highest correlation between observers 1 as well as observers 2. And so that is those are the findings for the liver fibrosis staging that we used in this study. So looking at those non-invasive markers of fibrosis, we found that the OPRI score predicts severe fibrosis in autoimmune liver disease. And so this was for ESHOC stage. And what you can see here is a representation of the OPRI score related to the ESHOC stage. And so we found that at a cutoff of 1.45, that was correlated with increased fibrosis with very good correlation in kids with autoimmune liver disease. This next one looks at OPRI with the Medivir classification, and this had a slightly different cutoff score for OPRI, and that was at 3.11. And that may be related to the differences in the classification systems of severe fibrosis. The FIB4 score predicted severe fibrosis in autoimmune liver disease as well, and this had a cutoff of 0.63. As well as the Medivir classification had a slightly different, when using that fibrosis staging, had a cutoff of 1.44, and these were fairly highly correlated. What's important about this, though, is that they're only able to designate severe fibrosis, but they weren't able to help differentiate very well at lower stages of fibrosis, or does it correlate with an ESHOC of 1 or an ESHOC of 4? It's just kind of an overall viewpoint. And so this is where the use of MRI comes in. And so this is liver stiffness by MRE. It's a predictor of fibrosis stage by histopathology. You can see here on the left the liver stiffness, which is in kilopascals, connected to the ESHOC stage. And you can see an increasing ESHOC stage as you see higher liver fibrosis and for autoimmune hepatitis and autoimmune sclerosing cholangitis, PSC. And this shows the relative proportion of each of these stages, or each of these liver stiffness, the ESHOC stages. And so what you can see is these darker colors are higher fibrosis stages. And you can see that in the liver stiffness, Values in the lower area using these cutoffs have lower fibrosis stages, kind of going forward using E-shock. And the liver stiffness by MRE also does this with the Medivir classification. You can see the same convention. So increasing Medivir classification with liver stiffness and the relative proportions, that there are higher numbers, a higher proportion of the samples that have higher fibrosis stages when you go increasing liver stiffness. So remember I said that OPRI and FIB4 weren't very good at differentiating between the different stages of fibrosis. And it turns out that MRE is actually better at doing that. And so this table shows that for all of autoimmune liver disease patients, as well as autoimmune hepatitis and autoimmune sclerosing cholangitis, you can actually identify this E-shock stage and a cutoff that correlates to each stage. And so here you can actually have a better idea that based on the liver fibrosis, liver stiffness that you get by MRE, you can better approximate a stage of fibrosis by E-shock, both for all kids with autoimmune liver disease, and then also highly more individualized cutoffs for autoimmune hepatitis and autoimmune sclerosing cholangitis, PSC. It turns out that this actually works pretty well for Medivir as well. And you can see here that for all kids with autoimmune liver disease, you can identify cutoff scores for Medivir classifications of 1, of 2, as well as 3 and higher. And you can do this for autoimmune hepatitis and autoimmune sclerosing cholangitis, PSC as well. So what does all of that mean, and what conclusions can we take away from this? And so autoimmune liver disease, as we discussed, can be characterized by progressive fibrosis. There are no non-invasive ways to assess fibrosis stage in autoimmune liver disease that have been proven. OPRI and FIB4 can predict severe fibrosis in autoimmune liver disease, but however, it's not quite as good at determining incremental fibrosis stage. However, liver stiffness by MRE is a predictor of fibrosis in autoimmune liver disease, with an ability to predict the specific fibrosis stage when assessed by histopathology or histology. So there's application for patient care, clinical trial designs, and kind of how does that relate to what we may think about doing here at A-LiNK? And so thinking specifically about research applications for A-LiNK, the implications would be, should sites include OPRI or FIB4 scores as part of their pre-visit planning and assessment? And how would we incorporate this into the process for assessing portal hypertension and other complications? Would this mean kind of something that we would note? Would this kind of help drive care? The other thing is, could we use liver stiffness by MRE as a surrogate marker of liver fibrosis in clinical trial design? We talked previously about, looking at steroids and different steroid effects in autoimmune hepatitis or GGT normalization in PSC. Would using that in conjunction with MRI be a way of taking a non-invasive look at liver fibrosis, both at the beginning of studies and potentially as endpoints? I think that as part of this, and part of why we share this research, is because it would be great to get, to talk through kind of other potential ways of utilizing this in clinical care. I'd like to acknowledge the Center for Autoimmune Liver Disease specifically, and especially the patients and the families who are part of this and part of this research and have dedicated their time and energy into making these studies possible. And then to Alex Smithkey for kind of heading a lot of this research, and for the research support, as well as the research team, our radiology and pathology colleagues, as well as our biostatisticians. I'd be happy to take any questions.
Good afternoon, everyone. I'd like to thank the organizers for allowing me to share our exciting work. I have no relevant financial disclosures. As we all know, PSC, or primary sclerosing cholangitis, is a chronic inflammatory condition affecting the bile ducts. 75% of patients with PSC also have concomitant inflammatory bowel disease, IBD, usually ulcerative colitis. The underlying pathophysiology or mechanisms driving biliary injury are unknown, therefore hampering the development of effective medical therapies. As we are all aware, there are currently no effective medical therapies for the treatment of PSC. Although PSC is thought to be autoimmune disorder, it has been refractory to our conventional immunosuppressive agents. Th17.1 cells are a subset of immune cells that secrete pro-inflammatory cytokines but are resistant to corticosteroid therapy. There are some early data to suggest that these cells may play an important role in the pathogenesis of PSC. Fibroblast growth factor inducible 14, or FN14 for short, is thought to play an important role in autoimmune conditions like lupus, but its role in autoimmune liver disease in children has not been studied. We started our study with 3 specific and interrelated aims. Number 1, to use liver gene expression and immunofluorescence studies to characterize immune pathways inside the liver that may be driving pediatric autoimmune liver disease. 2, to use proteomics, the study of proteins in the blood, to identify relevant networks in order to discover novel therapeutic drug targets for the treatment of autoimmune liver disease. And aim 3 was the functional aspect of our study. We used flow cytometry to study the role of the significant proteins identified in aim 2 on the expression of key inflammatory cytokines in the immune cells derived from children with autoimmune liver disease. This was a single center study of children cared for at the Cincinnati Children's Hospital. Aim 1, we had 24 liver biopsies collected from clinically indicated liver biopsies for our gene expression studies. Of those, 21 samples were available for multiparameter immunofluorescence. For aim 2, we had a total of 102 plasma samples available for our proteomic studies, of which 20 patients overlapped with our gene expression and immunofluorescence studies. We had 28 samples from patients with autoimmune liver disease and concomitant inflammatory bowel disease, or ALD-IBD, 61 patients from patients with autoimmune liver disease without IBD, and we had 23 healthy controls. For aim 3, we used peripheral blood mononucleocytes, or PBMCs, from 3 children with PSC-IBD to test the function or interaction of the relevant proteins identified from our proteomic studies on the expression of pro-inflammatory cytokines. For our gene expression studies, we had 24 children, 12 of which with autoimmune hepatitis, and 12 with sclerosing cholangitis, including autoimmune sclerosing cholangitis and primary sclerosing cholangitis. There were 10 females and 14 males. Each patient underwent a research MRCP as well as a clinically indicated liver biopsy. The biopsy sample was used for both gene expression studies and, when available, multiparameter immunofluorescence studies. The heat map shows an unsupervised hierarchical cluster analysis, which is an unbiased computational approach to group patients based on similar gene expression. The patients segregated into 2 main clusters based on similar gene expression profiles, cluster 1 and cluster 2. The pathways associated with innate immune response, Th1 interferon signaling, and Th17 polarization were upregulated in cluster 1 compared to cluster 2. In contrast, pathways linked with extracellular matrix remodeling was upregulated in cluster 2 compared to cluster 1. When we looked at the patients segregated based on clusters, we found that 100% of the patients in cluster 1 had an abnormal MRCP compared to only 15% of patients in cluster 2. Patients in cluster 1 were also older and more likely to have concomitant inflammatory bowel disease. Importantly, these patients in cluster 1 had a higher cholestatic markers like GGT and had higher liver stiffness measured by MRI elastography, suggesting more advanced disease. For our immunofluorescence studies, we used 7 different stains on a single liver section. DAPI stained the liver nuclei, FOXP3 for regulatory T cells, ROR-gamma T, and TBET are master transcription factors for IL-17 and Th1 polarization, respectively. PAN-CK decorates bile ducts, and CD4 and CD8 stains for their respective cell surface markers. CD4 positive, ROR-gamma T positive, or CD7 or Th17 cells trended towards increased expression in the livers of patients in cluster 1 compared to cluster 2, but did not reach statistical significance. Next, we examined CD4 positive or gamma T positive, T-bet positive cells representing the Th17.1 cell population. As you recall, these cells express pro-inflammatory cytokines and are resistant to glucocorticoid therapy. Liver Th17.1 cell populations were significantly increased in cluster 1 compared to cluster 2. Furthermore, there was a higher proportion of Th17.1 cells making up the total Th17 cell population in cluster 1 compared to cluster 2. In cluster 1, 73% of the Th17 cell populations were Th17.1 cells, compared to only 31% in cluster 2. This was statistically significant. For proteomic studies, we used the SomaScan platform to study over 1,300 plasma proteins in 102 children. After correcting for false discoveries, there were 9 proteins that were differentially expressed between patients with AILD-IBD and healthy controls. Since most of our patients with AILD-IBD had PSC, we focused the analysis on patients with PSC-IBD. FN14 had the highest fold change in patients with PSC-IBD compared to healthy controls. FN14 had augmented expression in our cohort. In other words, patients with PSC-IBD had the highest levels of FN14, followed by those with PSC without IBD, and healthy controls had the lowest levels of FN14. FN14 concentrations also correlated with liver enzymes ALT, AST, important inflammatory cytokines including IL-17 and interferon gamma, and with MMP7, a novel biomarker for patients with sclerosing cholangitis. FN14 also trended with GGT, but did not achieve statistical significance. In our functional studies, we examined 3 samples from patients with PSC-IBD and examined which immune cells expressed FN14. We found that in the unstimulated state, FN14 was primarily expressed by mononucleocytes and macrophages. When the cells were stimulated, there was a marked increase in FN14 expression in both CD4 and CD8 cells. Lastly, we wanted to see the effect of blocking FN14 on the expression of key inflammatory cytokines. To do this, we measured the expression of interferon gamma and IL-17A after stimulation alone and after stimulation in the presence of a monoclonal antibody that specifically binds to FN14, effectively blocking it. As shown in the green bars, interferon gamma and IL-17A expression was significantly increased from baseline upon stimulation in all cell populations. Remarkably, this expression was significantly suppressed when the cells were stimulated in the presence of FN14 antibodies, as shown in the blue bars. This suggests that FN14 plays a role in Th1, Th17, and Th17.1 polarization in children with PSC-IBD, and that blocking this protein may attenuate the expression of these pro-inflammatory cytokines. In summary, hepatic Th17.1 polarization was enriched in children with PSC-IBD. FN14 had augmented expression in patients with PSC-IBD. FN14 modulates Th1 and Th17 polarization in PBMCs derived from children with PSC-IBD. Lastly, FN14 may represent a novel therapeutic drug target in patients with PSC-IBD. I'd like to acknowledge everyone's work, particularly Dr. Methke with all his mentorship, Rebecca Carnes for her statistical analysis, Emma for the amazing work with the immunofluorescence, Asta for her help with the flow cytometry, and Annika with the immunofluorescence as well. And most importantly, a huge thank you to all the patients and their families for supporting our research efforts.